and thank you very much for joining us for these updates in the myeloproliferative neoplasms, what needs to be known for 2025. I'm Masarova from MD Anderson Cancer Center in Houston, Texas, and it's my pleasure to give you some overview of the hottest topic. So I will be focusing on essential thrombocythemia, polycythemia, vera, and myelofibrosis as the classical 3 myeloproliferative neoplasms without Philadelphia chromosomes. They come with the various symptoms and quite burdensome and often quite impacted quality of life, even for patients with the newest diagnosis and early essential thrombocythemia, which unfortunately have also quite early onset in certain population of patients that we call young adults or AYA. The typical presentations that would be cross in these diseases and overlap in some or the other extent are significant constitutional symptoms, thrombotic complications that are the highest in polycythemia vera, but still definitely significant and non-negligent with essential thrombocythemia and myelofibrosis, especially in the early phase. And unfortunately, the risk thus increases as people age with the disease. Organomegaly, progressive cytopenias are the most concerning symptoms of even more advanced myelofibrosis. However, also essential thrombocythemia and polycythemia patients that live with the disease for 1 or 2 decades could present with quite significant organomegaly without having a typical progression to the next phase of the disease. And then unfortunately, the most serious complications for people being diagnosed with polycythemia vera and essential thrombocythemia is progression to myelofibrosis, which we call secondary myelofibrosis or myelofibrosis from polycythemia vera or essential thrombocythemia, or unfortunately also acute leukemias, here abbreviated as AML. They could happen more frequently from myelofibrosis, but unfortunately also sometimes from essential thrombocythemia or polycythemia vera. So our goals of therapies would be to basically provide improvements in quality of life and foremost decrease thrombotic risk, particularly for people with essential thrombocythemia and polycythemia vera, and then hopefully to be able to prevent the disease progression, as I mentioned, to myelofibrosis or acute leukemias. The diseases are characterized by overactive JAK-STAT pathway, which is a pathway that is involved in production of blood cells, and unfortunately also one of the major inflammatory pathway. That's why these diseases are characterized by significant overactive of production of inflammatory cytokines that are reflecting and representing in the disease symptoms, burden, and splenomegaly, as well as ultimate progression. On the left side, I have shown or highlighted the drivers, as we called, which means the responsible mutations or genetic events that happens in these diseases and then ultimately drive the disease behavior throughout the years. With essential thrombocythemia and myelofibrosis sharing very similar background, where majority of them would have the typical JAK2 mutation, which is JAK2V617F, a little technical term, but most of people would be aware of this because it was a breakthrough event discovered for these diseases. We finally learned what is driving these disorders to basically be involved in the stem cell or the cell associated with the bone marrow cell production. And then carlaticoin mutation that was discovered the latest, but also represents about 20 to 30% of patients with essential thrombocythemia or myelofibrosis respectively. I'm mentioning these mutations because they currently now have involvement and targeted development for more specific therapies that will hopefully be able to halt and achieve what I said, disease progression throughout the years. And then polycythemia vera, it's a very unique diagnosis, which is mostly driven only by JAK2 mutation. In more than 96% of a patient, the specific JAK2 V617F, but also less common exon 12 or others that we do not know, would represent only less than 0.5% of these mutations. So the mutations have been known, discovered, and play different roles in disease behavior. However, we were not able to target much of the background of them and achieve what we call so-called molecular remission or alleviating the mutation burden to hopefully, what I like to say, set the clock backwards and make the disease not behaving so aggressively. The key issues in controlling these diseases are basically combination of all of these presentations, which means for essential thrombocythemia, polycythemia vera, overproduction of blood counts, where essential thrombocythemia would come with high platelets, polycythemia vera with high all counts, but efficacy as well as monitoring would be tied to red cells or something called hematocrit. complications of the cardiovascular symptoms, possible consequences, and bleeding and thrombotic risk. Here, I'll emphasize correction of other cardiovascular risk factors, paying close attention to blood pressure, sugar, lipids, cessation of smoking, overweight, regular physical activity, and healthy lifestyles. Then control of various symptoms and complications, as mentioned in the previous pellets, but also here, all kind of disease presentations, constitutional symptoms, splenomegaly, and poor quality of life associated with across these diseases that should be part of addressing the disease control, and then potential progression.